You've already heard about liver transplantation, so I'll just try and pick out a few things that interests me and talk a little bit about the outcomes of combined liver and kidney transplantation. I'll emphasize over the course of my talk that this is pretty rare stuff. There aren't many institutions with significant experience. So when you hear people talking about 10 or 20 cases, it represents a very large experience. And I'll try and bring out some of the lessons I've learned. I follow on from a very nicely demonstrated talk from the transplant surgeon at Stanford, which is an excellent unit. Thanks, Sergio. At King's, we've done about 1,400 liver transplants since I first started in 1989. We've transplanted somewhere between 40 and 50 children under 3 kilos, which for me represents the extreme of liver transplantation. And maybe I'll say a little bit more about that during the course of the talk. So liver transplantation has been around since 1967. That was Tom Starzl reporting the first successful case. This is Carl Groth, who was one of his first fellows and trainees who brought liver transplantation back to Europe. And you can see that many of the early survivors were actually children. The reason for that is they are robust. They don't have cardiopulmonary disease. They will take a tough time during theatre, and they have much better powers of regeneration and recovery after transplantation. So they were a good group to learn on. And you heard the North American experience, which is most kids are transplanted with whole organs. They have enough for various reasons, and therefore transplant surgeons in the US are very risk averse in terms of cutting livers down. The first combined liver and kidney transplant was performed by Margreiter in Austria in 1984. It seems quite recent, really, or at least it does to me. I've said it's an uncommon operation in children. And I think the challenge only comes when you get to the very small children. I think if they're missing veins, missing the inferior vena cava, it's very easy to replace those. That's, I would call, really quite standard. But the challenges, I think, are when you get below 6 months, and as I say, for me, the critical landmark is 3 kilos. And the smallest transplant or the smallest child for me has been 1.7 kilos. And that takes it down to where you have to be very, very careful with the veins when you're suturing, because it becomes very fragile. I think what Chris was saying about psychology, I believe strongly we should all be seeing psychologists and having some form of therapy for counseling us through these things. Because when I'm training my younger colleagues, it's not just the technical aspects that they have to be adept with, it's managing the tension in theatre when you've got a small child and things may not always be going quite so smoothly as they show in various talks. And to try and keep your nerve and to allow yourself to grow and develop experience safely, I think is probably the most important thing that I've learned in my career. Because if you get burnt early, you're never quite the same person, certainly the same surgeon. The other thing I'd like to emphasize is that perioperative management can be very complex in children, primarily because of the metabolic diseases that you're transplanting for, that all have little aspects, nuances of management that require specialist knowledge. So building a team of specialists and having really good colleagues that you can trust for their judgment and decision making, I think is essential. Now, what are the groups? I've put this here, this is sort of academic really, but it's useful to have a framework. So there are 3 scenarios. You have a disease that leads to damage of the kidney and liver together. The most obvious disease and the most common we transplant for is polycystic kidney and liver disease. The second group is where they get end-stage renal disease caused by an abnormality, a metabolic disorder in the liver. Now, for a liver surgeon, when you're treating this group, the liver looks normal. The liver looks normal, but there's an abnormal enzyme being produced that is damaging the kidney or another organ. And then finally, you've got a third group where you get both, liver and kidney disease together, And I would say the most common now in young adults is chronic rejection of the liver with CNI renal injury. So the most common indications, and I'll briefly refer to the top 3 in this talk, are primary hyperoxaluria type 1, polycystic liver and kidney disease, the autosomal recessive form, and methylmalonic acidemia. There are other much rarer indications that you'll see when you're reading papers, but really the numbers being performed in the literature are tiny. One of the things I want to say is where you have an abnormal liver, so particularly referring to the polycystic kidney group, the liver disease takes an unusual form. Most people have it fixed in their mind that liver failure, liver disease means jaundice. Actually, it's jaundice in a proportion of patients, but the majority of patients coming to liver transplantation with end-stage liver disease will not be jaundice. They'll have synthetic failure or shunting of blood related to portal hypertension. So in the group of patients that you'll tend to see in the kidney world, where they've got fibrosis in the liver and portal plate malformations, they have portal hypertension. And that's quite subtle. So you need to be looking at the size of the spleen, the presence of varices, shunting, in severe cases, encephalopathy. But they seldom get liver failure. So if portal hypertension dominates the clinical picture, they can get recurrent sepsis. It can be quite difficult to see, is it coming from the kidney or the liver? And we can sometimes have quite significant discussions about that. And the other important thing to say is that the liver and kidney disease progress at different rates. So in the polycystics, the kidney disease will usually manifest earlier than the liver disease. And trying to assess, do you do a kidney alone or a combined, can be quite tricky. You've heard about transplantation today, so it's all sizes, all ages. About 85% of our children will get a partial liver transplant, a piece of liver. So it's quite unusual to get a whole liver. If technically everything's okay, the grafts grow with the kids, they don't need a retread every 10, 15 years. If you go back 30 years, probably 20% of children were required retransplantation before they reached adulthood. Now it's down to about 10%. And it tends to be early technical complications that cause the troubles. Hepatic artery thrombosis, or as we saw in the case presentation, portal vein insufficiency. Actually, in that case, I think it was collaterals, siphoning blood away from the portal vein that went unrecognized. And the long-term outcomes improve. So 1 year survival for us, for a straightforward case, I'd expect to be 97, 98%. Our outcomes are slightly less good than that because we're taking on acute liver failure. We're taking on some, I think, sometimes fairly extreme cases. And the final thing, as with kidney, living donation provides an advantage. So this is an important slide. Here is the left lateral segment. It's about 20% of the liver that's transplanted into a child as effectively a whole liver. Okay, so these kids are getting the right liver mass. It just isn't a normal configuration. This is living donation. This was our first mother-child combination 31 years ago. And this is what it looks schematically. You can see good-sized liver sitting comfortably in a sort of anatomical position, and the quality of the grafts are good. The technical complication rates go down because the blood vessels you're anastomosing are slightly bigger than if you're using a size match from a young child. And this is where it starts to get more tricky. This is the liver from a neonate with neonatal hemochromatosis. And this is where we're transplanting the children under 3 kilos. And we've been able to use, for example, living donors to transplant children down to 3 kilos now. So the combined liver and kidney transplant, well, it combines aspects of both, and we've done it as deceased or living donor. The living donors tend to be sequential. So the children will get a liver, say at age 6 months or a year, they'll grow a bit, and then they'll get a kidney. and they'll often get the kidney from the same donor, and that has worked extremely well. As you sit here after lunch, your liver accounts for about 2% of your body weight. So most of you will have a liver weighing about 1.5 kilos. If it's more than 2 kilos, you should come and see me at the end. And the liver, whether it's whole or partial, is implanted first, and it goes into the right upper quadrant. For us, with the liver, we're taking good quality donors. They're under 40 years of age, by and large. Primary non-function is rare. I can think of 3 or 4 in 1,400 transplants, whereas delayed kidney function seems to be more common. I won't talk about the complications, I don't think. So what is there in the world literature? Well, the first thing to say is this is data from the US, and it was over a long period of time, 1983 to 2016. And you can see that whilst there are over 7,000 combined transplants in adults, in children there are only 297. And the other striking thing is how few were under 1 year of age. So I think that reflects a number of things: a reluctance to transplant small children for much of this period of time. Up till 1988, children under 10 kilos were turned down for transplantation. So there's been a change there. And also a lack of referral of the very small children until quite recently, because it was thought their survival would be too poor. So at the moment, there's somewhere between 10 and 30 combined liver and kidney transplants being performed worldwide. So if you look at the North American data again of 150 odd primary transplants, you can see that the patient survival at 1 year is just under 90% and just under 80% at 10 years. And the liver graft survival seems to be just a little bit better than kidney, but obviously this does not reach statistical significance. And what I put at the lower end here is the isolated liver and kidney patient survival over that same period of time. If you look at the pediatric transplant program in Poland, it's the only one that does children in Poland, so they are the national experience. They reported 25 combined cases. This was 5 years ago, with a reasonable follow-up of just over 4 years. But you can see their patient group was rather older, median age of 16, with a patient survival of 92%. Again, with the kidney graft outcome being 84% at that median follow-up of just over 4 years. And here, looking at the polycystic kidney disease, what I want to draw your attention to is this bit up here. The children's median age of 10 years, they had portal hypertension due to congenital hepatic fibrosis, platelet abnormalities, and with a liver and kidney graft survival of 72 and 88%, again with a similar sort of follow-up. This is a paper from Birmingham looking at small children. They define the small children as being under 15 kilos. That's usually somewhere between 12 and 15 kilos in weight. And the donor to recipient body weight ratio was 4.8. That's high, okay? I told you normally it's 2. Once you get that high, you start to see blockage of hepatic artery and portal vein related to the thickness and compression of graft. And what they reported was that the survival seemed to be the same as for children greater than 15 kilos, 87 versus 93%. So that's good. So what about the specific indications? Well, primary hyperoxaluria, I won't say too much about the condition, other than to say we now have genetics that provide guidance as to how things are going to play out over the longer term. The discussion in the literature has been, should we be performing combined or sequential? And even now, what I believe in is preemptive liver transplantation. I think it still remains very controversial. In this particular condition, I've put out the outcomes here, that at 10 years, patient survival for this condition is 69%, with 60% of livers surviving at 10 years. You can see the date is 2005, and I think things were really very different at that time, and we will have improved significantly. I think the problem with primary hyperoxaluria is every child is a little different in their genotype and phenotype, and you get this widespread oxalate deposition, which can affect cardiac function. So whether you do liver first or combined, I think is determined by the child size and occasionally by the systemic disease extent. For me, if we could do early diagnosis, identify those that we expect to run a very aggressive course, and transplant them before their EGFR falls below 50, then you can preserve their native kidneys for long periods of time. In this paper published recently, again, a single country experience of 18 children with primary hyperoxaluria. They were looking at the long-term outcome, which was a median survival of 9 years. You can see they have improved. The kidney at 15 years is a 75% graft survival, and for the liver, it's 85%. They had one death in this series, which was a child with Down syndrome who died early post combined liver transplant. You can see their experience is primarily combined. And the reason, I'll pass over that. And the reason for that, sorry, I haven't got it on the slide, is that the majority of their patients were a little older, 12 years, and therefore I think that influenced their decision making. They had a couple of children that were very young, but few under 6 months of age. So this has been the first paper published looking at preemptive transplantation in primary hyperoxaluria. And you can see in these patients transplanted that in 3 out of the 4, the renal function remains stable over a long period of time. And that's been our experience as well. When we reported our experience of 8 children, we had 3 who underwent preemptive liver transplantation with a GFR of 40. And out of these, only 1 has required transplant about 8 years after. And the world experience says that if the EGFR is greater than 50, you can expect native kidney survival to be in excess of 10 years. So I think that's meaningful and helpful in terms of managing these patients. One of the other conditions is methylmalonic acidemia, which is again a rare autosomal disorder. The liver looks normal, they get kidney failure. Actually, this is a systemic disease. These are children that are tricky to manage infection. Stanford, whom we heard from, published a fantastic series of 14 cases, older children than we tend to see at King's, with a mixture of indications for transplant, including renal disease and metabolic. You can see 12 whole grafts and only 2 partial grafts, but they published 100% survival with 1 liver retransplantation. That for me is the gold standard internationally. These are tricky children to transplant. They get a lot of complications. The wound healing isn't particularly good. And then I'll pass over this because I think it's sort of come and gone. We were encouraged to go into a program of doing auxiliary liver transplants in conjunction with kidney transplants for sensitized patients. You put the liver in, it mops up all of the antibodies, and then a few hours later you can put the kidney in, and people were reporting successful outcomes. This is a scheme of it. Actually, we use auxiliary liver transplant in acute liver failure. We have a child that comes in, put an additional piece of liver in, child survives, wait a year, the liver recovers, wind down the immunosuppression, the graft atrophies, and their native liver grows back. For a child, it means life without immunosuppression, which is a huge advantage. So, in summary, it's an uncommon procedure, very uncommon. There's been debate in the literature about doing simultaneous versus sequential, but as I've said, it's usually dictated by the size of the child. And for me, 6 to 12 months is the benchmark for small to large, the extreme under 3 kilos. There are some advantages of a combined it protects the kidney. You see, I think, better survival of the kidney graft in the long term. But if you can do a sequential from a living donor, as we've done in conjunction with our colleagues here, that to me is a fantastic way of doing things. And with the advent of genotype and phenotype, the advent of new medications, it's changing the field quite rapidly. So I make a plea that good outcomes are associated with complex team working. The complex surgical side, I think, is straightforward. That's what we're trained to do. It's the complex team working around the child and the family to produce a good result. And the plea is everyone thinks everything's finished on the day of transplant. The parents say, oh, thank God the child survived transplant. And you say, well, that's our expectation. They don't die in theatre. This is where the challenges start. And for me, the challenges are both in the short term, getting them through the first 6 weeks when there is a risk of them dying, into a long-term program. But all of these kids are coming into adult life now. There's a whole cohort coming through, and they need specialist care of people who understand children's disease within an adult context and to manage them through their adolescent and early adult life when they're at most risk in the whole course of their transplant life. Thank you.
So, you have a question?
Yes, I do. Nigel, just want to ask you something that we talked about at times. When you transplant these children, when you take healthy livers which are enzyme deficient, why do you think that we are not proceeding and implanting those livers maybe in some senior donors in whom the enzyme defect might not cause that many troubles as it did in children? For example, somebody who is in the desperate need of a liver transplant, I'm sure they wouldn't mind getting a enzyme deficient liver if that's going to mean that they're surviving.
Yeah, so that's a good question, and the answer is we did do that. We've probably done about 40 domino transplants where you take one out of someone and give it to someone else. We did that first for familial amyloid polyneuropathy, and we were the first people to report de novo disease in the recipient of familial amyloid polyneuropathy. And it was very painful to see someone develop a neurological condition that slowly progressed. He came to retransplantation purely because of that, but he was left with a long-standing neurological injury. We were the first person to report that. That was 9 years post-transplant, but now it's become well recognized, and the threshold for developing de novo disease with that condition is somewhere between 8 and 10 years. I've seen other people die as an outcome of that, and even when they're 75, I mean, it's getting closer to home now. You know, it used to be so far away, it didn't seem important, but now, now it's even 70s starting to look quite young. It is very painful and very hard. In India, in China, they're taking a piece of liver from 2 children with different metabolic diseases and crossing them over. Well, within our clinical governance structure, what worries me is 5 years down the line, people have forgotten what the real diseases were they were transplanted. A child may get jaundice, and they say, well, that's okay, it's conjugated jaundice. Actually, it isn't, it's unconjugated, and they'll get a brain injury or something like that. Primary hyperoxaluria, some people did domino them, but hey presto, they get primary hyperoxaluria, and then they get kidney injury and kidney damage. And that's because of the dissociation between what goes on in the adult world and what's going on in the children's world. The crossover isn't always great. Maple syrup disease is probably the most commonly exchanged liver now as a domino. Again, within the context here, you know, this is a lifelong disease. This is going to go into another child under 5 years of age. They're going to have 80 years of exposure to not a normal metabolic environment. So they may be okay, but, you know, I have a problem with that. I much prefer to give them a cadaveric liver and be innovative about how I get people transplanted. So the answer is yes. I have quite a bit of experience. I have my reservations. That was a very long way of saying I don't like doing it anymore.